Good afternoon, everybody. There's one last person coming in, and then we'll make a start because we've got a certain amount to get through. My name's Ian Bowns. I'm involved with Sheffield Community Contact Tracers. In particular, at the moment, we have a vaccine subgroup that's been looking at vaccination uptake, among other things, and that's what my colleague Nick Payne is going to be talking about shortly. We have two speakers, just to repeat ourselves from the email. Nick's going to talk about vaccine uptake and equity, and Abdul Shaif will be speaking after him about some of the work that's going on to try and improve vaccine uptake across the city, some that he's involved with directly. And perhaps other wider work. But I'm not going to do any more to introduce the speakers. I'm just going to get straight on because there's a certain amount to get through, certainly in Nick's presentation, that will take a little time. He'll be speaking for 25 minutes or so, Abdul maybe for 10 minutes, then we'll have a few questions, and then hopefully we'll find a little bit of time to have some discussion in breakout rooms as to what additional things we might collectively do to improve the situation, particularly for those who are finding it difficult to access vaccination. So without further ado, over to Nick.
Right, okay, good afternoon, everybody. I'm just going to share the screen and get the slides on. Just give me a second to do that.
Oh, sorry, while Nick's doing that, I forgot to do the thing I just asked Alex about, which was just to say that we will be recording this so that the talks can be available later on the Community Contact Tracers website. So if you don't want to appear as a small square image somewhere on the corner of any of the video, just switch off your video and that should preserve your anonymity. Apologies again. Back to Nick.
Okay, I guess everyone can see the screen now. Yes, good. Okay, my name's Nick Payne. I'm an honorary professor of public health at University of Sheffield, and now, as well as that, I'm a part-time volunteer vaccinator in Sheffield for COVID, and previously I've been a director of public health in the North Derbyshire area. And we, that's Ian Bowns and myself, who just introduced himself, are going to report on work we've done to examine variations and, importantly, inequalities in vaccine uptake in Sheffield. So there's quite a long introduction, but it's important to take you through this fairly slowly and carefully to make sure you know what we're talking about. So this is just to say what I will be talking about. I'm going to start off talking about the information sources that we've used and the maps we've produced. I'm then going to say a little bit, just as a summary of COVID and the position about COVID in Sheffield. Then I'm going to go straight on, not to vaccination and so on, but to talk about what we've done in terms of looking at affluence and deprivation in Sheffield, which you'll see seem to be pretty important in terms of the whole of this. We'll then look at variations in COVID case rates in Sheffield. And finally, we'll get on to vaccinations and variations in inequalities in uptake rates across the city. And we won't just look at the overall pattern, we'll try to look at ways and means of understanding the reasons and drilling down into local differences. And then we'll end by summarising what we've done and found and begin to think about what we can do to improve things in the future. So, sorry about that, just seem to have a problem advancing the slides. Right, okay, so all of the information that we've used here comes from publicly available sources. So for example, the first one here is on the government website, government.gov.uk on coronavirus, which provides information about the occurrence of COVID cases and admissions and deaths at various levels, various geographic levels, from nationwide to small area level. The next one is NHS England website, which provides data about COVID vaccinations, the same sort of data, both nationwide and at small area as well. And finally, we've used data which has come from the local government Ministry of Housing, Communities and Local Government, to look at measures of affluence and deprivation across England. So these are all the data that we've used comes from nationally available, and no passwords or anything like that required, no special sign-in. Anybody can get these data. Here, first of all, just is a summary of where we are with COVID in Sheffield. And this is as up to date as I could make it. It was downloaded yesterday, I think it was. So in Sheffield, we've had around about 43,000 cases of COVID. And the graph that's on the top there shows the rate, the rate per 100,000 population. And you'll see the smaller peak on the left is the first peak, and the much bigger peak that's you can see sort of towards the center right starts in around November, and which takes us to the present day on the far right at the top. And you'll see that the lighter of the two blue lines is the rates in people aged under 60, and the darker of the two blue lines is the rate in people aged over 60. And you can see that the population rates, case rates, the number of people reported as having COVID has thankfully dropped away from the high peak that it was in the winter to much lower levels now. Not as low as it was last summer, but still, but very much getting that way. And you can see that the older population rate, that's the dark blue line with the 30 at the end, which is 30 per 100,000, has declined more quickly and is splitting away slightly from the group aged under 50, aged under 60, which is almost certainly due to the influence of the vaccination program. And you can see that as well with the deaths. Sadly, there have been about 1,138 deaths from COVID in Sheffield. But again, these have substantially dropped down now, and arguably the deaths rates have fallen more quickly, or to a greater percentage than the case rates. Again, which is a reflection, I believe, of the success of the vaccination program, of protecting the population at most at risk, and most at risk from the worst effect of COVID. Okay, so that's just a summary of where we are. Right, now here we go to some geography. So it shows a fairly familiar picture of Sheffield in the sense that you probably recognise the overall outline. The middle of Sheffield, the city centre, is where that line saying central is. These are approximately electoral wards. They're not exactly electoral wards, but with familiar areas like Stocksbridge, Mosborough, Darnall, Ecclesfield, and so on. And we could have done the analysis at this level, looking at 28 excuse me, areas within Sheffield. But what we decided to do was to divide Sheffield, or use the fact that Sheffield is divided into smaller areas, which have got the rather cumbersome name of middle super output areas, census areas. I'm just going to call them MSOAs. But you'll see there's 70 of them. The map's divided like in a jigsaw with 70 pieces. And they're still fairly recognisable. I've just labelled a few of them just to sort of get your bearings, really. The one right in the middle of the city, Cathedral and Kelham, is labelled there. Stocksbridge right up in the north, in the far south west, Dore and Werlow and Burley in the more southeast. So they're all moderately familiar localities, but there are 70 of them. And this gives us the opportunity to look at at what's happening at a rather finer grain level than the 28 that we had before. So I apologise for their long and cumbersome name, but we'll just call them MSOAs, and that's the map of them that Sheffield is divided into. But importantly, lots of information about COVID in terms of cases and vaccinations, and in terms of other things that's available at this level. So, perhaps slightly surprising, I'm not going to start off with anything about COVID cases, let alone vaccination, but the patterns revealed when you look at the differences between poverty or socioeconomic deprivation and affluence within Sheffield. So the map is going to look familiar. They're all going to be, in the next sequence, they're going to look something like this. But this one is the pattern when you look at the differences in poverty and affluence within Sheffield. The map uses a well-known measure that some people here will know all about, called the index of multiple deprivation. And that's what's shaded with the colours on the map. And the most well-off areas in Sheffield, that's the ones with the lightest sort of greeny yellow colour, are as affluent as more or less anywhere in the country. But the poorest and most deprived areas rank among the most deprived in England. So we see sort of Sheffield as a sort of little microcosm of England as a whole, from the most affluent to the most deprived areas. We see that range across Sheffield. And as what I want to draw your attention to is what the map looks like. Just if you sort of, screw your eyes up and don't look at the detail, just look at the patterns of the dark blue sort of violet, which is the most deprived areas, compared with the greeny yellow, which is the most affluent areas. And you'll see, as the box says, the areas of highest deprivation, or darker blue, are mostly concentrated in the MOSAs to the north and east of the city. So just keep that picture of Sheffield in your head as we look at some maps to do with COVID itself. So here at last is a map that says something to do with COVID. And before we got onto vaccination rates, we thought we'd map the COVID infection rate by MOSAs, these small little areas in Sheffield. So first of all, the differences between the darkest areas and the lightest areas aren't trivial. They're quite substantial. The worst affected areas, shaded in the darkest of blue-violet, have case rates up to 10 per 100 over a 6-month period. In other words, 1 in 10 of the population seemed to have tested positive or had a COVID positive test in those areas. But in the least affected areas, the areas with the lightest colours, the rates are as low as 2 in 100. Or in other words, only 1 in 50 of the population, not 1 in 10, but only 1 in 50 of the population have had COVID. And importantly, and I hope you can see and remember this, the map is very much like the last one, which plotted deprivation and affluence. The highest case rates, the darkest bluey-violet areas, are in the most deprived parts of Sheffield. And as it says, the areas with the higher COVID rates are also tend to be in the north and east of the city. So this is not looking anything to do with treatment or vaccination or anything like that. It's just looking at the number of reported cases, or the rate of reported cases per head of population across Sheffield as a whole. And that's the pattern that you see. So finally, we've got onto something to do with vaccination. So when we look at vaccination, we're plotting it in the same sort of way. So the map overall looks pretty familiar. But let's just start off to look at the range in vaccination rates. Some areas, and they're the ones that are shaded, again, the sort of yellowy green, in some areas, 95% of the population have had a vaccination. 95% of the population aged over 65 have had at least 1 vaccination. In other words, only 1 person in 20 hasn't had their jab. But in the darkest blue areas, that's the lowest vaccination rates, less than 75% have been vaccinated. So as many as 1 in 4 haven't had the advantage of the protective effect that vaccination will give you. And you'll see that, as I said, the type of map's the same. The proportion of people that have had the COVID vaccination is what's plotted, and the darker the area, the lower is the vaccination rate. The lighter is the area, the greater the vaccination rate. And sadly, the map looks very similar, as we've seen, to the overall patterns we've seen already. It looks very much like the first one, which plotted deprivation and affluence in Sheffield. The lowest vaccination rates are in the most deprived parts of Sheffield, or as it says on the graph here, vaccination rates are generally lower in the north and east. And this pattern is sort of like a repeat of what we've seen for the case rate, but in the opposite direction. So the more deprived areas have higher case rates, but lower vaccination rates. So it's just to summarize this. So I put those two maps together. There's on the left, the deprivation and affluence map. The darker areas are the areas that are more deprived. The lighter areas are the more affluent areas. And there's the vaccination rate. The darker areas are the areas that with lowest vaccination rate, and the lighter areas are the areas with higher vaccination rates. And so that's the overall pattern. It's not quite as simple as that, though. So that's what we've done. We've compared the deprivation and affluence map with the COVID vaccination map. And I hope you can see the similarities. But it's not all as clear cut as that, because there are interesting and important exceptions. So just look at the top exception. That's Stocksbridge, which in terms of its deprivation affluence map, you might expect to have quite a low vaccination rate, but it's actually got quite a good vaccination rate. And the same is true for the lower red circle, which is Batemore and Jordanthorpe. It's got quite a high deprivation score, but quite a good vaccination score. And so some of these things, we don't know exactly what might be the explanations of those, but you'll also notice on the map there are red circle, there are small red blobs, not just the big red circle, but small red blobs. And the small red blobs are where the vaccination centres are placed. So there's a sort of circle of them around the sort of circling the middle of Sheffield. But you'll see there's one up in Stocksbridge, and there's indeed one down in the lower Batemore and Jordanthorpe area. So maybe, we begin to see that a little bit down in the southeast as well. And it may be that just simple physical access to vaccination centres is really, really important. But that's only just one of the things that might be important. And it's important that the advantage of looking at this sort of level across the whole of a city is you can perhaps see the more important detail like this and understand what is going on. In other words, you can see the wood for the trees in perhaps a way you wouldn't do if you examine this across the whole country, where you just had a massive map or tried to look at the two of what's going on. People understand an area the size of Sheffield and can say, well, actually, yes, I do know what's going on there, and it's the way they'd handle it in this area and stuff like that. So it's not just we're learning about Sheffield here, but I think we're learning about some general principles as well. Okay, so now the next series of slides, I sort of are slightly more for the people that are familiar with this sort of plot than others. So that the overall pattern is the message I've just been giving with the maps and so on. But for those people that sort of this sort of picture sort of explains things, I'll just go through a few slides that look in a little bit more detail at vaccination and deprivation rates in Sheffield. So we're going to have a series of graphs that look like this, and they're a bit complicated. So I'll just go through this one first. What we're plotting in each of these little red dots here is one of these middle super app areas. So, for example, I happen to know that this one down here is Cathedral, right in the middle of Sheffield. This one here is Nether Edge, and we'll label some of them up in a minute, but that's what they are. If you plot them where this scale here along the bottom left to right, is how affluent on the right or deprived on the left they are. In other words, they're plotted index of multiple deprivation. And if you plot on this way, the proportion of the population vaccinated, you'll see that an area like here at the top right is a very affluent area. It's right at, well, these here are very affluent areas, and indeed they do have high vaccination rates. But these areas down here are more deprived parts and less areas of greater poverty and so on in Sheffield, and they tend to have lower vaccination rates. And there's actually a graph, you can plot a graph, plot a line to join them up, and it's clear that this is unlikely, this pattern of graph is unlikely to occur by chance. But there are some areas that fall well below the line. Some areas, for example, right down here, which are substantially below what you might expect compared with others. So that these areas down here have very low vaccination rates, even though they're, in terms of affluence and poverty, are the same as here with quite high moderately high vaccination rates. So by drilling down and looking at where these places are, you can say, well, hey, what's going on here? What's happening in these areas? So why are some of these areas down here not doing as well as perhaps you might expect? And what's going on here, for example, where you've got a fairly affluent area which hasn't got a very high vaccination rate compared with others? So this sort of scatter plot, as it's called, is quite useful for examining and saying, well, actually, what is going on in these different areas? And it can ask questions about the way vaccinations are organized and any other things about the area that we might want to look at. And we're just going to look at that in a bit more detail. And here, I'm afraid the graphs get even more complicated, but bear with us. I think what we want to show you is the sort of thing that we can do with the data and the sort of thing we can do to try and help us understand it. So it's plotting the same thing again. It's again plotting vaccination rates and deprivation. So all the dots are in the same position. There's a little tiny one down there and all that and stuff like that. But this time what we've done is we've made the size of the blob, like these big ones here and these little tiny ones here. Okay, there's a tiny one there. Proportional to the number of people aged over 65. They're all plots of the 65 plus population vaccination rate, but the actual numbers of people over 65 in each area are shown. And this one here, Cathedral and Kelham, sort of hit the national BBC website news because it seemed to have a very, very low vaccination rate, as indeed it does. But this has a tiny number of people aged over 65, whereas some of these bigger blobs have much, much more, much larger numbers of people over 65. And there's a slight tendency to see that areas that have a higher elderly population, irrespective of how deprived or affluent they are, tend to have higher vaccination rates, maybe because services are just more geared up to older people in those areas, but who knows? And then this one here, oh yes, that was just to highlight what I've just been saying. Some areas with low vaccination rates also have very small numbers of population over 65. So we needn't particularly worry too much about these areas because it wouldn't take much to get their vaccination rates up to scratch. But we're more concerned about an area here with lots more people when we would like to see their vaccination rates up at this end, not down here. Okay. This is another slightly complicated, well, definitely complicated. It's the same plot, again, the points are in the same position, but this time the color of the blob is proportional or indicates the case rate. Do you remember we said that the case rate varied from around about 2% to up to 10%? Well, the dark blue blobs are sort of 8 to 10% case rate areas, like these here, and the lighter blobs, these, and these, are, especially here and here, are ones with a very low or a relatively low COVID case rate, only about, well, under 4%. So, and there is a bit of a worrying tendency, I mean, more than a worrying tendency, for areas with a high, as I think the next slide shows, yeah, areas with higher COVID case rates tend to have lower vaccination rates, and this of course is not good news. We do not want to see areas that have low vaccination rates being the ones that have high COVID case rates. These are just the areas where it's important to have really high vaccination rates and drive the COVID incidence down. And then if you want to be really clever, you can plot two things at the same time. You can plot the size of the population, which is the size of the blob, little tiny one down there that you can virtually scarcely see, or little tiny one there. And also the case rate is shown by the same colours as you've seen before, where we see this time, as you go this way, you tend to get a lower COVID rate in the more affluent areas. But as you go that way, you tend to get a higher elderly population, which, irrespective of the other thing, tends to be associated with a higher COVID vaccination rate. So there's all sorts of interesting things going on, and what we're trying to explain is that this sort of data analysis gives you a real handle about what's going on in terms of explaining and understanding what's happening in order to try and get COVID vaccination rates to a level where we're going to really achieve all the benefits that it could achieve. And just finally, in terms of maps, this is quite a simple map. It goes back to quite a simple map now, with not with rates and stuff like that, but it just shows where vaccination is still needed, so that the shading this time is just simply the number of unvaccinated over 65-year-olds. So in this area right in the middle here was this city centre area with very few older people. There's only 38 people over 65 unvaccinated here. That's not too bad at all. Obviously this area here, 265, and other areas 187 and so on. Well, there's a lot to be done here. Even quite affluent areas, because they're having quite large numbers of older population, have still got a way to go with 124 in Dor and so on. But it just simply understanding, well, look, where does vaccination need to find the people that have missed out and help them get vaccinated. This sort of map is quite useful. So after all that, just to summarise where we are, the first thing is that what we're saying is that routinely and readily available data can be used to map COVID case rates and vaccination uptake. There are significant variations in inequalities in vaccination rate overall, with more deprived communities tending to have lower case rates, with more deprived communities tending to have lower vaccination rates. And the so-called inverse care law, which by and large says those in most need of healthcare often have the least uptake and availability of it. The inverse care law, by which those in most need often have the lowest vaccination uptake, needs to be addressed. In other words, those areas that not only suffer from being having more socio-economic disadvantage, but also higher COVID case rates tend to be the ones with lowest vaccination rates. And nonetheless, important differences between localities need to be understood in greater detail. So, for example, where vaccination centres are located and other things to improve vaccination, to best prioritise and plan how vaccination is actually delivered. And that is the end.
Thank you very much, Nick. That's explained quite a lot. I hope those people who don't readily cope with numbers have managed to survive that, because some of us are used to that, some of us less used to it, and I'm glad that Nick took such patience in taking us through it. But what I would like to do, just while Nick's finished and it's fresh in people's memories, are there any actual questions of kind of fact or clarification, rather than discussing the messages that gives, that anybody wants to ask while Nick's still here? I can't see anybody with a hand up or anything, nothing in chat. So if everybody's reasonably comfortable with the messaging there, I'll go straight on and invite Abdul to speak a little about some of the things that are being done to try and address some of these issues, which I think follows on naturally from what Nick's been describing. So Abdul, over to you.
Thank you, and thank you, Nick, for a very informative piece of work, actually. And good afternoon, everybody. I'm fasting today, so if I'm not making sense, you'd probably understand this time. I'm getting really hungry. It's the time of the day I'm getting really hungry and tired. We got together as BAME communities on 12th of March 2020, when the pandemic was at its early stages. And we got together as community groups. 14 groups got together because there was an expectation from the community that we as community activists or community leaders should be doing something to help the community. And rightly so that the community should have that expectation. So we got together because we knew that there was a pandemic. It caught us all by surprise, and we were fully aware that the system wasn't going to respond to the needs of BAME communities in the way that it should. And we knew we had to play our part. And we got together and formed what they called the BAME COVID-19 group, which consists of 14 BAME organizations in Sheffield. And we set ourselves a number of targets that we wanted to meet. One of those targets was to fight poverty through the pandemic, which is delivering food packs to the families. We have delivered till today, since March the 12th, 7,500 food parcels into community homes. And I think that's a fantastic achievement, considering that that was all done on a voluntary basis through volunteers in the community. We also produced 5,000 masks April, May and June, which we were able to deliver to care homes and to members of the community through the food parcels. We also connected with the Sheffield community contact tracers, which for me has been an excellent experience, because not being a medical person, it's given us a lot of knowledge, as Nick did today with his presentation. And that connection helped us, in a sense, to do the film Seldom Heard Communities, which I think is a fantastic film that projects what's happening within the community. That kind of work was done with a lot of humility and a lot of energy unleashed in the community at the right time. And I actually think that the BAME community, in a sense, woke up the system, because when everything was closed, I felt that the council and the Public Health Authority was quite slow to respond. I think they built speed up and responded well eventually. But I think our work within the BAME community and alerting the system to what was happening was an important element at the right time. What we did know, we had a lot of information within the BAME community about our own communities. We knew best what was happening in those communities. For example, within the Yemeni community, where I work, I was fully aware of the data that almost 98% of Yemenis live in a poverty-stricken area of Sheffield, like the Fairvale, Darnell, Bengrieve, or Firth Park. So we were aware where that community was, and we were aware that they were living in inadequate housing. And as a consequence, it was also multi-generation people living in one house. And we knew all these could be problems, and we knew that the Black community would be disproportionately affected by the pandemic, as is the case as we know now. So having that knowledge and having that information in the community helped us to work at speed in delivering the services that we were delivering. We developed a helpline for the most vulnerable, which opened 12 hours a day, manned by volunteers, to actually be able to signpost people or to give them advice or assistance. There was a lot of issues to do with universal credit that we had to deal with. PIPs was another major issue that we had to deal with. And the advice service having closed down as advice centres, and people were encouraged to use virtual means to get into contact with the advice workers, meant that we as centres kept open, because we knew that most of the Burma community won't be able to use the virtual system of Zoom, and that was prepared for them. So there was a lot of work being done, and I think one of the most important pieces of work that we did at the right time, which was April, was to do the leaflets in 5 key languages in Sheffield and distribute that leaflet to 20,000 households. That leaflet talked about hygiene, particularly social distancing. And we were able to deliver that leaflets to areas like Page Hall and Pitsmore, where people would gather normally to try and help people not to gather in small groups and observe social distancing. So that in a sense was the work that we did for many months. Much hard work has been done, and throughout the months we were able to build a relationship with the Public Health Authority and the council, and different organisations in Sheffield that were also working. So the Burma COVID-19 group was able to deliver services very effectively because of the knowledge base within the community, because of the understanding of the complex issues. For example, we knew very well early on that many black people in the city were working in key roles or in key jobs, low paid jobs, to sustain the NHS, drive our buses, drive our taxis, work in takeaways, work in corner shops. We knew that. We had that information within our community base, our community knowledge. And in a sense, that helps us to reach those people much more quicker than we would have otherwise. Going on to vaccination, we now work very closely with the council and the Public Health Authority, and we're working very closely with an organisation called SOAR in Sheffield at the moment to help encourage people within the Burma community and outside the Burma community to take up the vaccine. We believe very strongly that it's the only game in town. If people don't take this vaccine, they risk transmitting the infection to other people, and it's also a risk themselves. We're able to use the local mosques, the local imams, local traditional people, respected people within the community, respected women within the community, to be able to give that information to the community. We've started it by writing to members of our organisations. We've now sent over 5,000 letters to people, asking them to encouraging them to take up the vaccine, and trying to dispel some of the information that's going around that you're all aware of. So in the context where we've employed, within the Yemeni community, we've employed now 12 community volunteer champions who are going out door knocking, handing food parcels, but at the same time being a connecting point between us and the system and the members. These volunteers would go out, knock at doors, befriend the client, find out what their needs are, find out what their medical needs are. We've given them as much training as we can, but we're developing more training now with SOAR to try and help these volunteers. I'm aware that many other organisations are going to be employing community champions, so we could end up with 50 people, hopefully working within the community to encourage the vaccination process. I'm quite encouraged to know that within the Yemeni community, we've had a high take-up now. We've got the older generation take up. We've still got problems within the younger generation, because they find it more difficult to accept the fact that they need to get vaccinated because of the misinformation that's been going around. But overall, I'm quite encouraged that we can crack this. We can get more people within the BAME community to get vaccinated. Thank you very much.
Thank you very much, Abdul. That's really helpful. I think I would observe, because I've been looking at the national data, the data that we've collected for Sheffield. I've actually got for everywhere else in the country, and although we know that there are inequalities within Sheffield, there are other parts of the country, other inner city areas, and certainly parts of quite a significant part of London, where the overall uptake levels of vaccine are not as good as they are in Sheffield. So I think we have got inequalities to address, and there's room for improvement, but we thankfully don't have the room for improvement that some other places have got. What I would, and I think that's a credit to an extent, as Abdul said, to the public health authorities and the NHS catching up with the seriousness of the situation, but also with the community work that's gone on to support people, which may not have been the case in other parts of the country. Is there any points or things people want to pick up with either Abdul or Nick about what the data shows, particular points about particular patches? Anything that Abdul's mentioned or anything that people haven't mentioned? I can see Steve's hand up. So in the absence of anybody else, I'll say fire away, Steve.
Afternoon, everyone. Thank you for those two presentations. Want to pick up on 2 points, really. The first graph that Nick put up, showing infection rates over time, and noting from memory that the under 60s infection rate in November shot up dramatically, and a couple of weeks later the over 65s followed, which kind of says that the younger people were spreading COVID, and then it spread to the over 60s. And that then picks up on the point Abdul made, which is encouraging the youngsters to get vaccinated, because ultimately people who are moving around will be the people who are going to spread COVID. It's very clear from that thing. And then just wondering that now that clearly the vaccination rollout has been very successful. So the acute problem in the NHS is solved, if you like. People aren't going to be turning up in hospital with COVID as rapidly as before, but the chronic problem of the NHS isn't solved. And one of the consequences of COVID from our last webinar is, of course, long COVID. And that can affect, I think, all age groups, young and old, and therefore there is messaging all the way around. So you protect not only the old by getting vaccinated, you protect yourself and you protect others from unbeknown consequences of COVID. So I think it's an important message we have to make. So yeah, that's my observation. So thank you once again, everyone. It's a brilliant presentation.
Thanks. I don't know whether Nick or Abdul want to add anything. If not, I'll go on to Jack. I see he's got his hand up. Do you want to fire away, Jack?
Thank you, Ian. Yes, and thanks to Nick and Abdul for great presentations. I wanted to pick up your point, Nick, about Stocksbridge and Jordanthorpe, possibly areas of deprivation, but close to vaccination sites, and you know how important a factor that is. And the idea, certainly the council have got some sort of mobile facility which they're planning to roll out in whichever areas are needed, certainly to do testing, I think. But there was also talk that perhaps vaccinations could be done from a mobile facility. So I just wanted your view, perhaps Abdul's view as well, about whether you think that's something worth pursuing, and where, perhaps which areas it might sort of do some work in.
Nick?
Yeah, I just Jack, thank you. I think the question about the sort of the mobile vaccination units is a really important one. I mean, people have tried that. I know there's one in South Wales. It's a converted travelling library, so it's quite big, but it's apart from the fact that it's rather daunting because it's got a picture of a syringe about twice as large as a person on the side. But apart from its logo not being very good, it looks actually a really good idea. We haven't got information, or at least I haven't seen any information about their potential effectiveness. But just in principle, it does. I've heard a lot of people anecdotally saying, "Look, if only I could just go across the road and get vaccinated, it would be totally different." And I know from vaccinating people myself, even in an affluent area, some people explain, you know, if you have time to talk to them about how much effort they've had to make to get there. And you think, well, for every person that's made a huge effort to get there under adverse conditions, there must be loads who've still got adverse conditions that haven't quite got the support to get there. So I suspect that's really important. And I suspect that's that's very much the approach that was taken with other important diseases to really get the case rates down. So I'd be enthusiastic about that, even if we don't quite know how effective they might be. There just seems to be, it's not just the fact that they vaccinate people, but they add extra publicity and so on. And I think it's a good idea. I'd love to be part of a mobile unit, you know, and actually sort of virtually like an ice cream van, and go out in the street and people would just have to walk across the road and get vaccinated. That'd be great. I'd love being part of that.
I would only observe that if people can. I've been in places in other parts of the world where cataract surgery is performed on on a mobile basis. So, you know, vaccinations are an easy thing to do.
Easy peasy, yeah.
It's not a huge issue or a huge risk. I don't know whether Abdul's got any observations on how acceptable that would be, though, to the various communities.
Just to say that we have had complaints about the distance people have had to travel to the vaccination centre, and we've had at least 8 clients that have asked for transport, particularly elderly ones, to those centres. And we have asked the Public Health Authority to provide us a centre nearby, and I think they're doing that within Bangreave and Fairvale area. I think they're doing that. I'm not sure what they've done it so far, but they did promise that they will have some kind of a centre in this area to deal with it, because people do have to travel quite a lot, and they have complained about that.
Yeah, and just linked with that, I mean, it's not just the physical distance that you look on the map. You've got to think, well, how easy is it to get to the place? So somewhere might be quite close, but actually quite hard to get to because there's a big hill in the way or something like that. On the other hand, somewhere might be a little bit further away, but it's actually really, really easy because there's a very good bus route. So that's where the sort of local knowledge is really, really important. And it does strike me that the accessibility is something that needs to be given a huge amount of thought, and understanding it on a small area level like we have done is just key to that.
Yeah, the one thing I would add as an observation is that physical accessibility is important. I think that I've heard other people describe issues that they've got with not being able to go because they've got caring responsibilities, and they might be able to go to get vaccinated, but they're worried about feeling unwell for 24 hours after or something, when they then wouldn't be able to fulfill those responsibilities. There's sometimes a bit more required that I'm not sure is all that readily available, and people don't know who to ask or how to ask. Unless we have any other points while we're here, what I'd suggest we do, I can't see Alex at the minute, but I'm sure she's there. If she's prepared to put us into some little breakout rooms to have a little bit more discussion about what we think might work and take this a little bit further. What I'd ask people to do is to try and think about what they or the people they're in contact with in groups in various parts of the city might be able to do in addition, and then come back perhaps in maybe 20 minutes with a couple of points each about things that they think somebody might do additionally, and then just have a quick report back before we manage to wind up on time at 5:30 if I chair this very well. So are we ready to run with those groups? There we go. So you'll need to accept the invitation on your screen to join one of the discussion groups. Welcome back. I'm trying to work out, we have 4 3s, 12, 13. Have we lost a few people, or are we still waiting for groups to return? I believe we had 4 groups, am I right, Alex?
Yeah, but I think they ended up being 3 in the end because there wasn't enough people.
Right.
To fill up the group.
Well, we were one of those groups, and I was going to. There were a couple of points I think made that it's worth us feeding back, but I was going to invite Louise and Mayor to feed back those 2 points, if that's all right, if we've got time. I don't know who wants to go first. Louise, you need to unmute yourself again. Sorry, it mutes you when you come out of the group, I think.
Okay, so we were just talking about the Roma community in particular, and the fact that there aren't any obvious ways of, communicating easily for them, and that I think their vaccine uptake is quite poor, and there's also a lot of there's a lot of transmission down at the schools in Page Hall. So this is Page Hall, and wondering whether the mobile COVID vaccination unit could be tried there. There are a couple of places it could go. And also, apparently there is a project muted, which should start quite soon, with 5 of the different community languages, not just for Page Hall, I don't think. I think it might be citywide, for questions on COVID vaccines, but I don't know much about that. But just trying to work out ways of talking about the vaccine. We have got a stall, we're going to try it down at Page Hall again. Let's talk about the vaccine and work with the people that are already working there, beavering away. That's it, really.
Thanks, Louise. Mayor, do you want to?
We are unmuted, yeah. Yeah, Steve, myself and a few others from the contact tracing group, because we haven't been contact tracing, have been doing some phone calls for Winkerbank Medical Centre, phoning people who've not responded to multiple requests to book vaccination. And it does feel quite important, an actual person to speak to, because some of these people have had texts asking them to book a vaccine, perhaps 6, 7, 8 texts. And we've gone into the surgery, worked in an office at the surgery, had access to their immunisation database. So it gives, you can check if there's been any update on immunisation, like if they've gone to the arena or somewhere, booked it themselves, and you can then phone. And a lot of people really were quite happy to have a bit of a chat. And fewer people than I expected were really anti. 1 or 2 people really didn't want a vaccine, weren't going to have it, and didn't want to be taken off the list. But most people I got through to were a bit hesitant, wanted to have a chat about it, and a few moved quite quickly to wanting an appointment booked. So it is quite important to give people time to speak, rather than it just being this rather impersonal text message. but it is time consuming, and I can see that the admin of a practice just haven't got the time to do this. You know, they welcomed us because of a link with one of the GPs there, and we worked just on the vaccine database. We didn't have access to any other patient record, and we had to leave some work for receptionists, telling them about numbers that were no longer valid and that sort of thing. So it took quite a lot of time, but I think all of us got some appointments booked for sessions at Flowers. And for the Winkerbank population, they didn't seem to be too put off by the fact that it wasn't at their surgery at Winkerbank, it was at Flowers. They all seemed to be fairly happy with that. And although there was a mix of languages, most had someone who came to the phone who could speak English. I think that's different for the Roma population that Louise is talking about. And I think there is a real need to have somebody available who can take time on a phone, and preferably with a range of community languages available.
Thank you. Right, do we have people from the other two groups to report back? Jack, I see you've unmuted.
So there was Abdul and Hulud and myself in our group, and we talked about how important this data is for Sheffield and for the authorities, so the council, the health service, the CCG, Director of Public Health, to have access to this data so that they can, you know, better do their job. And then we talked about how the relationship that SCCT has had with the council and public health hasn't been so good, and that we should try and improve that relationship going forward, so that we're sharing data and we're offering our support to what they're doing, and they're taking on board what we're doing from a sort of volunteer-led community group, and the importance of the volunteer-led community groups being able to be much more nimble and move faster to do things, whereas the council perhaps are, the bureaucracy of the council prevents things happening very quickly. But the old issue of no proper funding for volunteer community groups and no building of capacity, and that's really important because people are doing this as volunteers in their own time, and you know, it's not sustainable in the long run. So that was asked. So first thing was better relationship with public health, SCCT, better relationship. Second was proper capacity building within these volunteer community groups. And then the third was that SCC needs to continue to support the BEMA communities and the deprived communities. Abdul kindly said that he thought we'd been doing that fairly successfully, but it's just another really important part of the work, and that we need to be listening and supporting people in whatever way they feel we can, you know, just taking into account the sort of expertise and skill that is in SCCT among retired public health people, GPs, and all the rest of it, really. So they're broader things, but they support the sort of mobile stuff that we talked about, the focus perhaps on the Roma. Yeah, so that anything, I'm happy for Abdul and Hulud to contribute, but that's what we thought.
Okay, can I just respond directly to that, to the point about contact with the local authority and the CCG, because we did invite reps from both organisations who we know have got a role within the vaccination programme. We know some were away and were unable to attend, but others haven't attended, but without a reason. We did supply them with a short paper that outlined pretty much what Nick's presented in a kind of shorter form, because it should be language that those people are very familiar with. The other point I would make is that from the information point of view, we haven't got anything they haven't got. And I've been told in a short communication with another local authority off the, in a different patch, that they produce similar data, but they don't publicize it, supposedly because it's confidential. I just replied, well, this is already in the public domain. What's confidential about it? I didn't understand the issue.
Yeah.
So anyway, we have one
Group, yeah.
other group from.
Yeah. We had Sailor from the United States, and there was Carrie and myself and Steve. So we spent a bit of time talking about the situation in the States and explaining to Sailor about what we've been doing to date. So it's all been quite interesting. For instance, they've just withdrawn the, is it the Johnson & Johnson one, isn't it, Sailor? From the States. And that's going to severely impact, particularly in the short term, on their vaccination rates in the States, being withdrawn by the FDA. So that they have their issues. We then talked about, and I think it's repeating some of what has been said, about the vaccine hesitancy amongst the Slovak Roma group, and work that has been done to try and address that. And then we looked at the data that Nick produced, which is about the actual numbers in each MSOA is actually quite small in a lot of cases. It's all in the hundreds and 200s. So I think the work that's being done to try and contact people to actually sort of get over any barriers and hesitancies, particularly in the over 65s. So we looked at that, and then we also discussed about whether different strategies may be needed for the younger age groups, particularly because of the risk balance equation as you get younger. And we may see a different set of issues as the vaccination program rolls down the age groups, with lower uptakes and concerns, and probably the need to sort of try and address those concerns is in different languages and in different formats is going to be increasingly important. There was something else. Carrie was talking about something to do with GUNAs. Carrie, can you remember what you said? Is there something else that you need to add? So I've got. You might need to unmute, Carrie. Yeah.
Sorry. About the mobile unit, but also the fact that there's phone lines being set up, which is interesting as to whether that's reactive or proactive, whether it's phoning out to people or being there for people, maybe in response to the letters that Abdul was talking about, 5,000 letters that have gone out.
That was it. Yeah,
there's people on the ball ready to talk to people.
Yeah.
And also, and the mobile unit is important.
Yeah, the mobile unit. Yeah, we discussed that as well.
Right.
Quite wide ranging. Sailor, is anything you want to add from the United States perspective? You may need to unmute.
I'm sorry. Not at this time. It was just interesting to see how in your community that you're supporting the volunteers in terms of the contact tracing. So I thought that was important. You don't see that here as much. You only see the healthcare professionals kind of doing that. So I think that's important.
Yeah. Okay. Thank you.
Thanks.
And welcome. Please join us anytime.
Yeah.
It's interesting to see what other countries are doing to prevent it, preventative measures. So there were a lot of interesting things you guys brought up, the mobile units and things like that. So, and I think the pamphlets in different languages, that was important too.
Oh yes, there was a question to Abdul about the languages. Do you want to repeat that, Sailor? Carrie?
I was just curious what the prominent language were over there, because over here we have a lot of Polish, Arabic speaking. We have a lot of South Asian communities, and I think when you don't provide that type of guidance and material, then there's really a disservice that you're doing for the community. They don't know where to go, what resources to use. So I was just curious about the languages in that area of Sheffield that you kind of focus.
The leaflet that we did in 5 key languages. The key languages were Arabic, Urdu, Polish, Somali, and we also addressed the Roma community within that main leaflet that we did.
Right.
Abdul, have you got any points about the Roma community and ideas about how we can
one of my colleagues, Gulnaz, is I think intending to work with them through a program that we've got some funding for from the council. So we're just in the process of developing some ideas around that. I'll let you know when that materializes what we're doing, but that's that we're doing that with SOAR, with an organization called SOAR.
But anything we can do to help or support, or
any
information we can get out, and
one of the things that you can help us with, if because we have sent these 5,000 letters to members asking if there are any questions, if there are any medical issues and we're not able to get in touch with the GPs because you know how busy the GPs are, would some of you put yourself at service?
Okay.
The only thing I would say, Abdul, is that we find it quite difficult to give individual advice to patients we don't know and whose records we haven't got any access to.
Yeah.
Because we occasionally get questions that are very personal and very individual.
Of course.
We can answer things in general, and we'll do our very best to do that. But the usual advice, if it's really down to individual circumstances, is you've just got to fight your way back to your GP.
Which is what we will be telling them.
Which I know you know this, but it's just to stress it again.
Yeah.
It's very difficult sometimes to give advice when somebody just says, well, I've got an immune condition. There are quite a few immune conditions. They're a bit different from each other as well. But thanks. Well, I think we're at 2 minutes too late, so that's a complete fail from the chairman. Partial fail by the chairman. But I'd just like to finish by thanking Nick and Abdul, and particularly Abdul for it being relatively short notice. We only got in touch with you in the last week or so. So thank you very much for finding time to come and talk to people about the work that you've done already. And thanks to Nick for making all my impenetrable maps accessible to people who don't eat and drink data. And thanks to everybody else for some really great ideas. We will try and pick up some of these things in a contact with the local authority and the CCG. We have got those contacts. So I'm going to draw the meeting as such to a close, but could I just ask Nick, Alex, Fran, Steve, and possibly Jack, if he wants to just stay behind for a second so we can sort out a date when we meet next. So bye-bye.